So good afternoon, everybody, and you are all very welcome to our April Fields of Knowledge session, where we have, as you can see here in front of you, two very interesting guests who both work at the crux of rural mental health across New York State, which forms the basis of our discussion today. Just before we get into the nuts and bolts of today's session, and I introduce our two panelists today, just a real quick reminder on what the essence of Fields of Knowledge is. My name is Conor Hammersley, and I work as one of the research investigators here at the New York Centre for Agricultural Medicine and Health. And as part of our outreach efforts, we wanted to create, I suppose, more connection between research, between policy, between practice, and between community members also. So we set up these sessions to try and get a better hold on all those kind of aspects that form some of the challenges, or people that look or that engage in some of the challenges that rural communities face. And I think one of the primary objectives that we want to achieve from these is that they would be open dialogue sessions, and that particularly from attendees themselves, that they could pop in with questions, reflections, and thoughts, and that would be an essential part of these conversations as well. So I'd encourage anyone who's attended today to please feel free to use the chat function to share any reflections that you might have. I would just request that, like a lot of the topics that we discussed, they can be quite sensitive and people can have their own experiences with them. So if you could just be mindful of everybody when you are sharing any reflections, questions, or comments, that would be great. But please do use it as much as you want as the session gets underway. So without further ado, I'm going to introduce our panelists today. As I said, today's session is off the back of a statewide aggregated rural health needs analysis that was published a couple of weeks ago now at this point via the New York State Association for Rural Health. And the person who was the lead author on that was Joshua Grove. And Joshua is a PhD candidate in sociology at the Maxwell School of Citizenship and Public Affairs at Syracuse University. His research examines how social institutions shape mental health and substance use across the life course, with a particular focus on rural and underserved populations. He studies how factors such as religiosity, policy environments, and access to care influence behavioral health outcomes. Prior to returning to graduate school, Joshua worked as a pastor supporting LGBTQ+ individuals struggling with identity and substance use. And next up, we have Amanda Horner, who is an NPH. She's project coordinator for rural mental health initiatives at the New York State Association for Rural Health. Outside of working with NISAR, which is the acronym for the organization she works for, Amanda is a member of the New York State Public Health Association and serves in the Western New York Digital Equity Coalition. So, folks, you're both very welcome.
Thanks for having us.
We've had over and back conversations now a number of times at this point, so we're glad to get this out to the public domain. Amanda, we might start with you. I think once when I first read the needs analysis assessment, it kind of articulates for a lot of people, or puts numbers behind what a couple of people kind of have a sense of, or feeling, or experiencing themselves. But from your perspective, can you just give us a sense of what motivated this assessment, or what was kind of the preclux behind this work?
Yes, absolutely. Thank you so much, Connor, for that introduction and for having us here for Fields of Knowledge this month. We're glad to be here. So our report, the Statewide Aggregate Rural Health Needs Assessment, also known as the SARNA, really came about as we saw, an increasing level of conversation and prioritization of, or at least raising the awareness of, mental health as a priority. It's becoming more and more of a talked about need in rural communities, and certainly communities across the US, but the rural mental health aspect is unique in its own way, as rural communities are. We really wanted to understand, when it comes specifically to rural communities, what that current landscape is of mental health. And so with the SARNA, the goal was to take a look at county planning documents. So there's two kinds we looked at: the community health assessments and the local services plans. take those documents, see what they were saying about mental health in 44 of New York's rural counties. So we have 62 counties in New York, 44 are rural. Really take a look at what these reports and these documents were saying individually at the county level about mental health and aggregate them, bring them together, see what those common themes are across the counties of New York State. What are shared areas of concern, areas of need? Because what we were hoping this report would provide is some foundational information to support the strategic planning of collaborative efforts in rural New York to improve mental health and well-being on the whole. So that was really the driving force behind this, was we're seeing mental health as a concern. We want to see what those shared concerns are across New York. So then how do we take those concerns, elevate them, and provide some information to support collaboration?
Great setting. And I see people might just notice Destiny Tremblay, who works with us on Fields of Knowledge, she just put into the chat that report that both Joshua and Amanda were involved in. Just for context, Amanda, would you mind just quickly explaining what the community health assessments are and also the local service plans too?
Yes, so I'll start, and then Joshua, I'll invite you to add anything I might have missed as our primary researcher here. But the community health assessments and local services plans are local planning documents. So the CHAs, or the community health assessments, are really done from a public health perspective, whereas the local services plans, or LSPs, are coming out of the mental hygiene system. In New York State, we have kind of two different governmental structures for public health and mental health. So these documents are completed by different aspects of the counties or county governance, but both are looking at what are local needs regarding certain areas or topics related to health and well-being. And Joshua, I'll turn that over to you.
Yeah, the state, New York State, provides all counties with a prevention agenda, and those come from the CHAs and the CHIPs and the LSPs. The CHIPs are the community health improvement plans. So basically what the SARNA does, what I did was I went into all 44 counties and I read all of the LSPs, all the CHIPs and all the CHAs, which was, you know, a couple thousand pages of insanity. And what we were kind of look for was the diamond in the rough. Like, you know, all right, so we know that rural people, rural communities face certain mental health crises above, and in that is, you know, things like anxiety and depression and substance use disorder. And we were trying to figure out what we all have in common, right? Because if we want to fight this as a state and we're looking for funding, we're looking for players, we're looking for people that are interested in this fight, we have to know what we have in common. And one of the biggest problems that New York faces, and all of us face in the United States, is siloed systems of care. And when I say that, what I mean is people have to go to 3 or 4 different places to find the help that they need. So what we're trying to do with SARNA is kind of mainstream a person's problems so that they don't have to go to all these different places, but we can have a center where a person can say, hey, I can't pay my utility bills. I'm struggling. Can you help me look and how to figure out how to apply for SNAP? All of the crises that people face, we want to figure out how we can put a person in a pathway that they won't get lost.
I think from reading the report, I think one of the best things that comes out from it was, one of the really interesting things was the there was kind of the lived reality of it was great, in the sense that, because on the map you could see that there's resources here, there's centers here, but the operationalization of those, or the lived reality of accessing those, was much different than having just resources dotted here all over the state of New York.
Yes. Yeah, one of the crazy things, Amanda and I have been talking about this the whole way through. If you look at the SARNA report, one of the most interesting things is a lot of the data that we have is county level, right? So, and it's important to get underneath that to sub-county. So for people that don't know a lot about how research is done or what data we have available, the majority of data that's available to social scientific researchers is at the county level. There are also census tracts and zip codes that can be harder to find. But one of the interesting things that we have also in our, oh my goodness, Amanda help me, on the diversity dashboard, sorry, that we'll talk about, is you see like Tompkins County, for example, if you look at it, it might be shaded a light color saying, oh, hey, that's a great county to go to because they have access to mental health. They have access to different things. But when you look underneath it and you look at the different rurality of Tompkins County, right, people who don't live in the center of town at the county seat might live 40 miles from the most local place they can go for help. So even though it might be shaded one way, when you look underneath that, you see all sorts of different colors. And colors is not good. You don't want to see lots of colors. That means there's a lot of inequity and inequality in that county.
Right, and this is what we think great about the report too as well, because when people see it, they have the heat maps on it, and you can see. So am I right in saying the darker the color, the
exactly, yes, and heat is not good. Well, I mean, in New York, it's usually good, but not on the maps.
So just for context, so just for we were talking about this before we came up. Well, I got confirmation. I thought there was 64 counties in New York. There's 62 counties in New York. There's 44 outlined as rural in your report. What defined that? I would have assumed that there was a lot more. I would assume that basically everything north of Westchester County would have been assumed as a rural county, excluding Albany maybe, or that.
Yeah, you touched on it, and I'll let Amanda take on after I say this one thing. As a rural scholar, one of the biggest issues that we have is how we define rural, right? There are a lot of counties that are not in the 44 that have very rural places. They get very upset that they weren't included in the report. But how we define rurality changes from local to state to federal government. The government defines it through the USDA. There's a thing called RUCS, rural. I'm so used to saying acronyms, I can't remember what they stand for, but you guys don't care and it's okay. But they use a system, and then the state uses a system, and then they work together to figure out how to classify counties as rural. And it usually depends on the population, right? And also proximity to a major metro county, or major metro city or center. Right. If you wanted to add to that, Amanda. It's a mess, basically, is what I'm saying.
Yes, so I believe, like Joshua said, the 44 counties we selected were based off of population sizes. And yes, we have gotten some feedback on, well, what about urban counties that have significant rural populations? So to bring back what Joshua previously mentioned about our diversity dashboard, this is another tool that NYSAR has available on our website, and we really hope that those interested in the SARNA can also use the diversity dashboard as a supplemental tool. It is something that we've had for a while, but we recently did a big update of it. It combines different types of demographic data, social economic data, as well as different community health metrics, including a lot of the mental health metrics in the SARNA report. And we have that at the county, and for a lot of measures, the sub-county level as well. So looking at census tract and zip code. So even if, for example, I'm coming from Erie County is considered urban. Our seat is Buffalo. Buffalo is one of the largest cities in the state, but we do have rural communities in Erie as well. So where this county wasn't in the SARNA, we still have a lot of that sub-county data within the dashboard, so that people can go to, look at it, access it, and see, what are different measures and trends for those communities.
It's it's also important to remember too that we did more work based on the SARNA, which was a white paper and then an implementation guide, so that people who live in counties like Erie County that aren't in the SARNA, for example, we provide programs and talk about implementation of programs that will work in any rural community. It doesn't matter what the greater county area is like. You can go 10 minutes outside of Manhattan and cross the Tappan Zee Bridge and you're in the mountains, right? Mm-hmm. So, we take that into consideration as we've built up upon the SARNA with the diversity dashboard, with the implementation guide, and now with the white paper we just released last week that kind of does a deep dive into what does a program look like when you want to try and fix the problem of access to mental health treatment.
That's really interesting. I think, Amanda, thanks for sharing that, because I think that'll be really interesting to a lot of our listeners, in where you can access that dashboard and access that information. So just maybe we might go back to some of the findings from the report in that. And this might sound like an obvious question, but could you just speak about the extent to which because I know this was the central crux of the findings, and you talked us a bit, maybe Joshua, about the broader structural conditions in rural communities and how they impact access and how it's kind of this cyclical, vicious cycle of problem, limited access, problem getting worse, all these kind of things, you know?
Yeah, yeah. So one of the things when we did this, started the SARNA, I mean, it is a massive undertaking to figure out what are all the problems. But just as importantly, right, you have a person's household, and that's like the individual level that we talk about a person's experience. But if we move up into what's called upstream, right, we look at the drivers of what is keeping people in the situations that they're in. That's one of the things we look at. So we look at things like anxiety and depression, which are higher for people who live in rural counties. We look at suicide, drug use, housing, nutrition. All of these things play a central role in a person's mental health, right? So the structural things that we found, there are three really overarching problems that rural New York faces, and really what every rural area in the United States faces, that every state's dealing with, is to figure out things about the workforce, about transportation, and about telehealth. Those are the three major structural barriers that we have. Because if a person can reach a building where people work that they can be helped, what if nobody works there or they don't have enough staff? Right? So there are so many different problems. Maybe a person can't get there, they don't have a car, or they don't have broadband access. And the Build Back Better plan under Biden administration, one of the things that did was set aside billions of dollars to kind of create the infrastructure necessary in rural America to have access to broadband, so that if they cannot physically reach a doctor or a therapist, that internet access allows them to do that. And I cannot overstate the importance of telehealth and the magic that it has done for us in reaching people that are difficult to reach, who are in remote rural America. And there are a lot of people, you know, we think about, oh, they're small counties. Well, they add up, right? You know, we have millions of rural Americans that have that problem. So, yeah.
Would you mind telling us a small bit about that telehealth, how it works, how like what like in terms of why does that bridge the gap? Obviously, I know in terms of the sparsity and stuff like that, but if you just break that down a small bit for us, that'd be great.
Of course, Amanda, do you want to do that? I know you studied it too.
Yes, so I'll start, and then Joshua, I'll turn it over to you. So when it comes to access to technology in rural communities, this is another way that potentially we could access services to overcome geographic barriers. Like Joshua said, if somebody doesn't have access to reliable transportation to easily get to an in-person service, whether that's through lack of access to a personal vehicle, public transit, or the services themselves are just so far away that it's not feasible to drive there. You know, we're looking at upwards of a couple of hours round trips trying to get places in some situations.
Mm-hmm.
The idea behind telehealth, one of the ideas is that we could potentially overcome these geographic and transportation barriers, as well as possibly workforce too, if there aren't a concentration of certain types of health professionals in an area that are easily reachable. We could use telehealth to, with technology, access healthcare professionals, access healthcare services at a distance within the home, where it may be more private and more easy to reach. But the flip side of that is, in order to access services like telehealth, there's a lot that goes into it. So there's the broadband component, like Joshua said, we need to have access to reliable high-speed internet, and the infrastructure for that is not always present in rural communities.
Right.
But even if we have that internet, then we're also looking at, do we have access to internet-enabled devices that can access a telehealth appointment, something like a computer, a tablet, a phone? Do we have those devices? Do we know how to use those devices? So getting into more of like a skills component. In the digital equity space, we really look at a lot of these different features that all kind of combine to impact our access to technology. And that's before we get into questions of like health insurance reimbursements, which are a little bit beyond the scope of my role and knowledge, but at least from those components of do we have access to the technology and the skills and the support that we need to access these services? That's another big question.
Yeah, we're good at identifying need, and we're not as good at delivering the care that we've identified that's needed, right? One of the ways that is the most successful pathway to accessing, especially remote rural areas, is through the school system. And that not only talks to things like telehealth, but in that way, we're also looking at anxiety and mental health, generally speaking, and adverse childhood experiences. It's called ACEs, right? The schools are the best way for us in, because that connects us to the families. Because unless they're homeschooled, we have access to them and their families through the school. Although, homeschooling does have a higher percentage in more remote rural counties. But that's more due to, again, transportation problems than anything else.
Yeah, just at this point, you would remind any of the attendees, if anyone wants to pop in a question or a comment or reflection on what we've discussed so far, or anything comes to mind, please feel free to drop it in. Well, I'm curious to know, and I mean, I get we're kind of jumping from points and topics here. What are the findings what you expected it to be? I think it's quite bleak when you read the findings. Did you expect you expected?
Yeah. I hate to say this because it's an unfortunate reality. I expected it to be bad, and frankly, it was worse than I thought it was. And when I say that, I'm specifically thinking about two things. One, the level of anxiety and depression and general distraught of our youth. That's a real problem, and it's a real crisis. Anyone in this room, our cyberspace, is blown away by the cyberspace. I'm 50, so we're already amazed about the fact that we're all sitting here looking at each other on a computer screen when a lot of us grew up and didn't have computers in the house, right? How fast that's come. But if you have children, you also know how different high school and middle school and things like that are today for kids. And I think that I was taken aback by the reality of how harsh things can be, especially when you have lack of access to mental health care. We already know that mental health comes stigma, and people are afraid to get the help that they need. People are afraid to talk about the help that they need. That's especially true for boys. And the only way to get in there is just to keep talking about it and that's the only way stigma goes away, right? Is to normalize it. Right. But we have a habit in this country of not wanting to normalize pain, unless it's chronic pain that the pharmaceutical companies can tackle, then they have no problem with it. When we're talking about human emotional toll, right, we're less likely to talk about where we failed at helping each other.
Very well said. I just want to go back to, is there anything you want to say on that, Amanda?
No, I just want to echo what Joshua said in terms of the findings of the report.
I want to just hit back on a point that you mentioned earlier, Joshua, about silos and working in silos. We'll get on to farm silos in a bit. But for the time being, we're going to talk about organizations working in silos. And you know what? It came up in the session in Lake Placid last week, and it was something that COVID kind of prompted, if I remember correctly.
Yeah.
Could you tell me where that's at now at the moment? Do you think that's in a good? Is our partnership strong, or is it that something that still needs a lot of work? And how does that? Yeah, could you just give me a sense of that? I was going to ask, how does that break down into subpopulation groups then too, as well, that are even maybe harder to reach, even they're doubly disadvantaged even by the rural, which we can talk about again in maybe another moment or two.
Yeah. Well, what he's talking about, we had a conference at Lake Placid Rural Health Partnership. And there were 3 people on the panel who were all director of community mental health services in 3 different counties across New York. And they talked about the relationships across directors and across agencies. This is the same issue that I deal with in the work I do with in jails and prisons, looking at MAT, the medication-assisted treatment for people who are addicts in jail. The problems are that people don't talk to each other. The agencies, they don't talk to each other. And that's what we mean by the silo, right? Is that there are systems of care that are fragmented. So if you want to get help in one place, you can't necessarily get all the things that you need. And since the people you're going to aren't talking to the people down the street that help with another problem, then you're already at a loss. Mm-hmm. As a pastor, I ran into this all the time with people coming to me saying, where do I get this help? And I'm like, well, there are a lot of different places that you have to go. And so we take them by the hand and we navigate that. But the system is not set up to hold people's hands, and it should be, right? We shouldn't ask the person who's already in distress to figure out how to navigate a system that we can't, as scholars and activists and researchers, put together right in the first place. I get excited. It's really frustrating, because all people really need to do is just figure out how to talk to each other better. But a director said last week that I thought was so poignant, and I actually clapped for her. She said that someone had been working as a director of public health, and she was a director of community mental health, and the person had felt like she had stepped on their territory, because she felt, oh, that's something we deal with, that's not what you do. And so that feel of a need to control your own specific space creates that siloed system,
Yes,
right? And I understand why people are trying to have ownership of the problem, because they're passionate about it. But if we kind of mainstream the passion alongside our territories, then I think we'll find that we'll get a lot more done. And Amanda could speak to that, because she studies things like this better than I do. Sorry to throw you under the bus there, Amanda.
No worries, no worries. Yes, that's certainly a big theme that's emerged, especially as we started to take the SARNA from that assessment phase into more of an action phase of looking at, now that we've seen and documented a lot of these needs across rural New York, where do we go from here? What do we do with that? And so Joshua and we worked on our implementation guide. We worked on our white paper focused on integrated care. And a lot of the recurring themes there when it comes to actual practice is focusing on collaboration, focusing on getting different sectors, different agencies and organizations working together, because these are really big and really complex issues. And at the end of the day, it's not going to be one person or one organization that fixes it. It's going to be all of us working together, bringing in our unique perspectives, our different resources, our skills and talents to addressing these things together and building a more integrated health system.
Yeah, so in the white paper, if a person doesn't know what a white paper is, it's basically just it's us trying to talk to policy stakeholders, quarterbacks in the community that are leaders, and people who just want to know more about it, right? To talk about specifically, how do you do this? What's the best way forward? And so when we talk about all these things, what we're trying to do is put forth these programs that we've done deep dives into and say, hey, if you guys have a problem with managing anxiety among youth, here's a program that was implemented in such and such, and it's not all in New York State, but we took rural programs that have been effective, right, that have evidence-based realities on the ground that works. And we're saying, look at what these people are doing. You might want to try and do that. And of course, communities are unique as well. So you kind of, this is how you kind of tweak it to fit your specific background, whether you're from Texas or New York or California. If you're depressed, you're depressed, right? But the culture surrounding where you live matters. And so you kind of throw the ball to the local leaders there who do a good job. America Serves is a program that was started by IVMF at Syracuse for veterans and their families. And what they do is they go into towns, find the leaders in that town, and then talk about how they can work together to create collaborative care models where agencies work together to do the hard work of bringing people together, as opposed to making the patient do all the work.
Right. So you're saying you have that like regional adaptation, and then by extension you have cultural adaptation to it as well.
Exactly. Yeah.
I think it feeds nicely into Julie Sorensen's question here. So Julie's the director of our center here, and this kind of goes back to how I got to know Joshua and Amanda. I don't know if people know, you always have one of these people when someone produces a large body of work and someone goes through nitpicking what's missing in the work. And I was one of the nitpickers of this great report. I was this very irritating nitpicker.
Nitpicking is a good thing, though. It's a good thing. It's a good thing.
I was like, where's the farmers in this report?
Yeah.
No, I'm joking. But Julie was asked here, have our guests attempted to assess the successes of the mental health services that are provided for farmers? Since much of what farmers face is an existential crisis, I wonder how much counselling can help address the expansive issues farmers face. Josh, and I think it kind of comes back to a lot of what you're saying about the upstream stuff that we've spoken about before. And I know you've worked with farming communities. You've worked a lot in rural America before. Josh, if you want to jump in on that.
I have. Yeah. Thank you for that question. Julie, is it Julie? Is that her name?
Julie, yep.
Julie, thanks, Julie. Yeah, that's a great question. And that is true. That's how Connor met, because Connor's like, where are the farmers? I was like, that's an excellent question, because there's not a single word in the Starner report about that. And I appreciate that, because, we need to be thoughtful about, everybody, especially in the culture and in the local economies that run certain counties. Yeah, like I said, my dad and all of my grandparents grew up on farms. And when I was a pastor in rural Maryland and in upstate New York, I worked with farmers. Here, where I am in rural Maryland, we're facing the crisis that a lot of people are, where when I grew up 30 years ago, there were cows literally in my backyard. And now most of those farms have been sold for warehouses, for housing communities, as the urban sprawl from Frederick and DC and Baltimore, since we're only an hour outside of that, is coming here. And it really has transformed our town, and not always in great ways, especially when you're proud of being a farming town. Right. And I've seen, members of my churches have to close their farms or sell their farms, or bits and pieces at a time, because of the demands that they can't meet, because they're faced against industrial farming that's really taking away the small farmers' capacity to do any kind of work with any kind of living that they want to pass on to their families. And unfortunately, I can't speak to how the SARNA speaks to that, because it does not. And I don't have a lot of information on what the realities are on the ground for farmers in New York and what they're facing. And for that, I'm sorry. That's a shortcoming of mine that I don't have and I don't know. I know more about my own county in Maryland, but that's more because I worked here as a pastor in rural pastoral work. I'm not a farmer. We found that out fast when I grew up on my grandparents' farm and tried to, muck the stalls and cut the heads off chickens. It was not the life for me, clearly.
Well, I think there's just a universal point here, but like one of the things that, and how we got connected, I was just wondering about how I got connected with Joshua and Amanda, was wondering about like the intersectional nature of it, and looking at these things by, occupation, by class, by gender, and these kind of things. And it helps kind of put the microscope on different groups, because we know, like, across the country, and particularly in New York State here, that agricultural populations are also highly represented in adverse mental health outcomes. And I think there's two aspects to that. There's the dynamics of working in farming, or working in agriculture, or working even in the forestry or fishing communities too, as well, that you work at a job that is not conducive to conventional healthcare hours. That's even before stigma, all those kind of things come into it. You're at odds with the reality of, 9 to 5 operational hours. The only things that are applicable to you from that perspective are like emergency room hours, and that, which are very sparsely populated in areas. But that's only one aspect of it, and that's kind of on the micro aspect of it. I think that in a wider, and this is one of the points that I think Julie is coming back to, the wider socioeconomic aspect. So you think across New York State here is an interesting example. 2/3 of dairy farmers over the last 25 to 30 years have gone completely out of business. And like you think of New York State, it's so conducive to dairy farming. It's green grass, they grow grass very well, they can produce dairy farming very well. And look at some of the numbers in counties around here. There would have been, years ago, don't even talk about 2-3 decades ago, in the same generation, there would have been, vibrant communities of farms there, and which just aren't there anymore. I mean, we're talking about a farmer mental health crisis, or even a male mental health crisis. And when you break that down even more, you see what's going on in these kind of more working class male jobs, and you see they're in decline. And as you said, Joshua, industrial farming has completely taken over these things.
So, I mean, the subsidies usually go there now. They're no longer, friends with the small farmer. Yeah.
Right. And it's one of the things that's really struck me since I came. So people might have picked up from my accent. I'm originally from rural Ireland, and having spent a lot of time in rural New York now, I'm always struck by redundant farms, communities that were once vibrant no longer look vibrant, and in comparison to Ireland, which is highly subsidized supports, particularly from European agriculture, and that farms are still in business, community shops are still open and stuff like that. And if you're talking about mental health, there's a whole wider ecological aspect of that's associated with that. Sorry, I went on a tangent there, but
no, but that, that's an important tangent, because it made me think about the role of place. especially in rural economies. Rural economies are often localized, and what we saw happen with coal is happening with farming now. It was the case that farming economies in rural America were the backbone of rural America. That's where the tight-knit communities were. It was often, like it was where I grew up. But those realities are becoming less and less real across the United States for all the reasons that you talked about and that we've been talking about. And so the question becomes then, which is the question that faces all of us as people who are concerned about rural America, is what do you do about it? Right? I mean, what happened to the coal towns? Is that what we want to happen to the farming communities? What are the alternatives? How do we bring in an economy or strengthen an economy that's dying because of the things that we're doing to kill it? I mean, it's unbelievable how the government will say we need these rural transformation funds. Here's, $1 billion for each of the 50 states. Let's spend money on the problem. But at the same time, you're taking away the subsidies from the farmers that they need to exist. So it's a vicious cycle that has a lot to do with policy at the federal level. Extent of what it's able to do financially because of the funds that it gets from the government, specifically for things like farming and fishing. I mean, that's even kind of in worse shape. I mean, I don't know a lot, but I know that that's true.
Absolutely. I'm just wondering I think just one point that I wanted to kind of come back around to, and then working with in terms of bringing partners into the room and stuff like that, what we talked about. And I think we're more hard to reach groups like that. And farming is a good example. And I don't want to think that that's the only example in rural America, but it is like bringing farming representative bodies into the room who have an interest in the welfare of farming in the county or the state. And I think inherent in that has to be an interest in the welfare of the farmer and the community that you work with. And I think that's they're like partnerships that we often don't think about when you think about public health.
Yes. I agree 100%.
And I think you can make the point too as well for LGBTQ plus communities, maybe Joshua and stuff like that. And,
the government, some governments have done a good job. If you want to look at where the health is good, look at the relationship across the government and the private sectors and the public sectors and how they work together. The healthiest places in the United States are in places where the government and the people work together, because they know that if you want to help a farmer, put a farmer at the table.
Right.
The same thing when the government, teaches about education. It may not sound like this is relevant, but it is, I promise. They tell us how to teach kids and they create tests without asking the teachers how they should do it. It's the same kind of sentiment when it comes to rural America. If you want to know how to fix it, put rural Americans at the table, because the ones who are in Congress are not the people you need to talk to. It's the people who work on the farm every day, who go out in the morning and do the fishing, but they don't ask them to do it. Right. And that contributes to the stigma that already exists, that they're not good enough to be at the table of how we fix the problems that we have, that touch all of us, but they don't see that. I don't mean to make this a complaint session. It's just the reality of it.
Thanks a million for that, Julie. That question, Julie. Just if anybody else has questions or comments or reflections on what we've discussed so far, we usually try and finish up at about 2:45 or just after that. So if you have, please drop any comments, questions, reflections into the chat. I think to come at it from, and I know you've worked on some of this, and Amanda, you've been involved in some of this about like the next steps of Sarna and stuff like that. Do you want to just give us a sense of that and some of the opportunities that have stemmed from this, that have kind of opened up, or where you see the biggest kind of gaps to be filled there?
I'll throw this to Amanda, because she actually ran focus groups of leaders to see what they needed and what we want.
Yeah, absolutely. So when it comes to our white paper on integrated care for anxiety and depression, before we came to that topic, back in December of last year at NISAR, we convened a series of focus groups of our members representing all different types of organizations and counties within New York State to really hear, we've done this report that really aggregates, county documents. Now we want to hear from practitioners who are working in their communities every day in different sectors, different types of organizations and areas to see, what's the lived reality right now. Because as something we've kind of talked about in previous presentations is even with like these county planning documents, there's a lag in the data. So, and I'm sure Joshua can speak to this too, like when the data is collected, there's always a little bit of a gap between when it's collected and when it gets published. And then when we work with the published data, we might already be a few years kind of past when it was originally kind of collected and amassed. So we wanted to hear what's going on, right now and what in the SARNA is resonating with the current experiences of our members. And a lot of the discussion was coming across things like fragmented systems, siloed systems, the importance of, early intervention in anxiety and depression, making sure we're getting people the care, the appropriate care that they need when they need it. But then how do we do that? Questions about, screening and referral processes. We can screen for things like anxiety and depression, but then where do people go from there? If you screen positive, where do you make those referrals? Where do you make those handoffs? So a lot of really related topics, and that's how we really came to focus our white paper on, okay, let's look at this integrated care. Took a look at different models from our implementation guide, things like collaborative care, certified community behavioral health clinics was one we looked at. We looked at integrating primary care with emergency departments.
That's a big one.
Yes, that's a big one. As well as community paramedicine. So looking at emergency medical services and how each of these models addresses some aspect, maybe not everything, but it addresses some aspect of care. And then we thought, well, how do we potentially create a system that combines these different types of programs and elements to help move people through the healthcare system to really address their needs, scaling up or down, depending on their individual circumstances. So Joshua, if you have more you'd like to add about this kind of model.
Yeah, I think she said something that really matters, and I think anyone in this room understands it, that people without insurance and people who are poor, oftentimes they go together, but middle-class America is struggling with this, is that people get their health care from the emergency room. When they get sick, they go to urgent care. When they have a lump, they go to urgent care, they go to the emergency room. And that's what the majority of people without insurance do because it's their only option, because they can't afford a primary care physician. So, one of the first stops of figuring out this problem is to figure out how to provide adequate care and move from a reactive medical system and mental health system that we have. We're always reacting, we're not preventing. If we start from the beginning and say, what could we anticipate happening, and then build a system that prepares for that, then you're not going to have the problems that we have.
Right.
And I don't mean to make it sound like it's simple, because it isn't, but it is, right? It's just a matter of putting the right pieces together, and that requires putting the right people at the table. And one of the things I want to say before we finish is that one of the things I took away from reading every single LSP from all 44 rural New York counties are the people who are writing those and the people who are on the front lines are amazing people. The things that they're trying to do to get access to the people is nothing short of heroic. It's just that they're not giving them the necessary infrastructure to be able to do their jobs. They're overtaxed, they're overburdened, they're overworked, there are too many clients for too few doctors. There are zero, I know like 3 counties in New York State have 0 beds for child psychiatry. 0.
I know.
Some people have to wait months for treatment. There are kids spending weeks in the emergency room because we don't have adequate care for mental health. I mean, that's a real crisis. But we just kind of walk along like, la-di-da, everything's fine. So we're trying to, this is also a fire alarm, right? Saying we have a crisis here and we need to do something about it because people are really suffering in high numbers. And that's what one of the things we want the SARNA report to say is like, hold up, stop. We have a crisis. We need to figure out how to fix it before it gets worse, because it's getting worse. I don't mean to sound like doomsday, because I do believe there's hope. I just think that until we change directions,
right. It's the frontline workers that have to face the mercy of that, have to face it and see the brunt of these things, So, like, I'm conscious of time and that.
Of course.
So the white paper that was developed, who is that targeted at? Who needs to read that? The white paper. Who needs to be seeing this? What's required?
Yes. So, in terms of the white paper itself, so really anyone who's interested in the topic, we certainly invite you to take a look at the paper to learn about, a little bit more on, integrated care for anxiety and depression, the different program models we talk about. But we also include in the report specific calls to action for a couple different groups of community leaders, things like people like state legislators and policymakers, counties and community leaders, and then hospitals and clinical leaders. So really looking at like state governments, local governments and communities, as well as the hospital and healthcare system. We have some specific calls to actions with recommendations on policies and practices to start advancing rural New York towards more integrated care. To go back to what I had mentioned before, no one person, organization, or sector can fix for all time a very complex problem that has a lot of different factors impacting it. It's going to take a collaborative approach. It's going to take people working together across sectors and organizations. Each of us, working on what we know, what we do best, and then collaborating with others on what they know and what they do best towards that shared goal of making sure that the communities we are working with, that we are serving, that we are living in, have the best possible opportunity to live the best possible lives and to live well. And I think, at least for me, especially coming out of our recent public health partnership conference that Joshua and I were at last week, that sense of hope really comes from, I am hearing a lot more people talk about the importance of collaboration and looking for opportunities to work together to do work like this. So that's
very well said,
a huge spirit, kind of the through line between the SARNA and all of our subsequent publications is that collaborative spirit.
And I wanted to add to something that Julie had said in the chat that I wanted to add to about about counseling. And I'll say this: I mean, I'm biased. I'm a counselor and I'm a pastor, but I think that access to counseling won't solve the problem, but it will do for farmers specifically and fishermen and fisher people. I'm right, because you're mindful of the whole gender thing. That counseling and therapy provide people with the tools necessary to face the hardships that they have. And that's why, stigma is such a problem, especially in that community. But I've seen wonderful transformations in people that were in my church that would go to therapy and talk about the crises that they have with, having to sell their farm that their great grandfather had built. That can be the difference between a person having joy in their life and a person not, is understanding, what are the things I need to do in my life separate from my job that help me manage my job and all the problems that I have there. That kind of takes away from the SARNA report and talks more about, mental health upkeep. Like I had said earlier, reactive versus preventative, proactive. If people do the work necessary to build a toolkit so that when adversity comes their way in their jobs and in their livelihoods, they'll have the tools necessary to kind of make it through the fire, so to speak. I hope that's helpful, at least a little bit.
Well, I think that was a great closing point. Both those points were brilliant to close upon, because we can get too caught up in not too caught up, that's not the right word for it, but the acknowledging that all the structural challenges are there, but it doesn't take away agency completely from the individual either, and what therapy and counseling can offer that person.
Agency, good word, Connor. Yeah.
Folks, we're going to leave it at that. Thanks so much. I thought that was brilliant.
I'm so glad.
Joshua, that was really, really great. We'll have to get you on again for another session. So just quickly before people go, that Destiny has shared a follow-up survey in the chat. If you could just complete that, it'll only take 2 seconds at the end. That'd be very, very much appreciated. And just a very big thank you to the wider backroom team of Fields of Knowledge, Destiny from Blade, Alison Flanagan, and Katrina. Thank you so much for all the work you do in the background for making this work today. And finally, to our 2 panelists, brilliant work, and also to our attendees too. We're back again on the 27th, the last Thursday in May. I think it's the 27th at 2 p.m. And we're looking at the triple burden on farming women and its implications for well-being. So Josh,
I'll be there.
We'll have to get you back for that, Amanda.
Yes. I'll definitely be there in time. I'm glad to know about this. Thanks for all the work you guys do.
Okay, guys, thanks so much. We'll talk to you all soon.